Good afternoon, everyone. Thank you for being here. Happy New Year. And welcome to the Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I am today's facilitator. To help us with attendance, as some of you have already done, please be sure to type your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar on your Zoom toolbar, probably located at the bottom of your window. If you're joining via phone, please email your phone number and name to cstat@uthcsa.edu. We hope that you can join by video for the discussion portion of the latter half of the session, but no matter how you're joining us today, we're just happy that you are here to learn alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we ask that you stay muted unless you're speaking. There's quite a few of us in this space, so keeping your comments brief will allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or in our discussions. I hope you saw the announcement on iEcho yesterday, but if not, please note that our didactic today is on psychopharmacology for perinatal depression and anxiety, and will be presented by Dr. Karen Horst, who is a reproductive psychiatrist at Baylor College of Medicine, an assistant professor in the Department of Obstetrics and Gynecology, and who is also the medical director at the Pavilion for Women at Texas Children's Hospital. Following that, we'll have a case presented by Dr. Joy Subrin, and we will start with our introductions, followed by our didactic, announcements, the case presentation, and then an open discussion. Once again, thanks for joining us today. And so I'll start with our introductions of our hub team. We'll start with Dr. Anastasia Ruiz.
Hi, everyone. Thank you for being here. I'm one of the faculty attendings at Texas Tech Health Sciences Center Psychiatry Department. I am also the Regional Paramedical Director for the West Texas region, and I'm a psychiatrist. I'm just so passionate about maternal mental health. So thank you for all being here joining us today.
Thank you, Dr. Ruiz. Dr. Humphrey.
Hello, I'm Emily Humphrey. I'm a DNP. I currently practice in Waco, Texas. I have 12 years of experience doing inpatient and outpatient addiction medicine with a focus on women.
Thank you, Dr. Humphrey. Dr. Subrin.
Hi, good morning, everybody. I am Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health, coming to you from the University of Arizona in Banner in Tucson, where I am the embedded social worker in an OBGYN practice, focusing on women's health.
Thank you, Dr. Subrin, and welcome all of our team members. I hope I didn't miss anybody. And thank all of you for participating in today's session. We're glad to welcome Dr. Horst here as our presenter again. And now, Dr. Horst, I will turn this presentation over to you.
Oh, hello. Good, happy noon and 11 a.m., I guess, for you, Dr. Subrin. Is that correct? I'm trying to get my light to work so I'm not in the dark, but there we go. Okay. And I'm going to be sharing my screen momentarily. And we will get started. Okay. Are we good with the screen? Is it working? Yeah.
Yes, it is. We can see the screen.
Okay, thank you very much. All right, well, I am going to be talking about psychopharmacology during the perinatal period. And I'm still playing around with the gallery. There we go. I don't have any significant disclosures personally, and these are the disclosures for the ECHO group. Learning objectives, we are going to talk about dose range for SSRIs and SNRIs, how to integrate using a screening tool into the dose adjustment decision, and recognize possible etiologies, treatment options for postpartum insomnia. Unfortunately, we don't have a whole lot for perinatal insomnia or during pregnancy insomnia. But we can talk about that too. And the ideal situation is that we are seeing patients pre-pregnancy. So doing a pre-pregnancy consult, that's the gold standard. However, does anyone know what percentage of pregnancies in the US are planned? We are at 50%. So that gives us the other 50% of pregnancies are unplanned, and that's why so many of our patients come to us panicking if they are on medicine already. So that is actually one pearl I have already, is that for those of us who are seeing reproductive age patients, it's good to anticipate an unplanned pregnancy and give them information about their medication in terms of safety during if they were to become pregnant. Extra bonus to you if you also are thinking about asking about their contraception if they do not want to get pregnant. Basically, when we are talking to patients about treatment of their underlying mental health condition versus taking medication for that condition, what we need to talk about is how there's a there's no risk-free situation. Either way, there is a theoretical risk. And where we are right now is thinking that a symptomatic patient, that is exposing her pregnancy to more risk than the medications that we offer. So pearls, just sort of general guidelines if we are going to go there and prescribe medication, antidepressants, for example, for anxiety and depression during pregnancy. Ideally, we're going to minimize polypharmacy. We're going to dose to remission and try to help patients not have in their mind that they need to be at an arbitrary low dose. That seems reasonable, but it's not actually rational. We don't want two exposures. We don't want the pregnancy exposed to both her being undertreated and symptomatic and also being on medication. That makes no sense. The other thing to think about is that the pharmacokinetics and physiology of pregnancy change. And so we need to be dynamic and reevaluate patients throughout their pregnancy and be ready to go up on the dose. And then the other thing is, back in 2008, I believe the FDA put a warning on antidepressants saying that providers ought to consider tapering patients off in the third trimester. And that actually was reversed because it was so dumb. Patients are at the highest risk for having an episode in the early postpartum. And that's what happened when the FDA made that recommendation, and everybody started following the recommendation and taking patients off. So it really makes zero sense to have patients go off right before they deliver. However, those labels still show up on medication, on prescriptions. So be ready to counter that and tell them what I just said. So what medicines are we talking about? First line therapies are the SSRIs and SNRIs if we're talking about treating anxiety as well as depression. And looking across so we're talking about, let's see, I'm sorry, these are not my slides, so I will confess. I'm going to look at what it says. So, these are decent guidelines. I would say all of us develop, get to know these medicines and are more comfortable with some medicines than others. And the other thing is patients have a past history with certain medicines, and they may already be able to tell you what works and what does not for them. So these are, this is a list that is helpful, but don't take it as gospel. And you have to include the patient experience with medication and also your comfort level with these different medications. Let's see, other things in here. Yeah, the use of benzodiazepines during pregnancy. I just want to say that there was an old rumor that was poorly studied, saying that there was an association between benzodiazepines and cleft palate, cleft lip, and that has been disproven. So patients can take a benzodiazepine during pregnancy if that is part of their regimen and they need to be on it. Of course, there are many reasons to be very thoughtful about prescribing benzodiazepines, but they are not teratogens. Screening for bipolar disorder is recommended before any patient is started on a new antidepressant. So the use of the MDQ is a good one. And then the CD 3.0 is another good one. The CD is very short and it has a better sensitivity than the MDQ, but they are both good. And basically for general providers, a positive screen suggesting possible bipolar disorder means you don't prescribe an SSRI to a patient. How should we respond to positive screens for perinatal depression? This is a nice algorithm that is in our toolkit, and basically does the patient have moderate to severe depression? If so, yes, an antidepressant is indicated. Are they already on an antidepressant? If so, are the symptoms, is the patient in remission? If the patient isn't in remission and they have been on a max dose for greater than or equal to 4 weeks, you can consider other treatments. And we'll look at that in a minute, but I'm going to keep running through the algorithm. Other reasons to adjust. So you want to make sure you're following up with patients after 4 to 8 weeks and reassess, ideally with a questionnaire like the PHQ-9 or the EPDS for perinatal patients. And then you're going to consider changing, switching to a different agent, or making sure you go up to the max dose. You also at that point should be considering adding psychotherapy if the patient isn't doing psychotherapy. And then if they're not in an antidepressant, but they have a history of taking one that worked for them, you definitely want to go with that one. You do not want to go with the one that's safest for breastfeeding. You want to go with the one that worked for them. I guess I'll keep going and then we can absolutely come back and discuss this. Regarding the bottom, the bottom box here, let's look at that in detail. Again, as I said, you want to maximize other treatments such as psychotherapy if someone's not responding. In late pregnancy, you can consider increasing the dose even above the upper limit of the recommended dose range. And then you would want to see the patient, make sure they're not having any signs, symptoms of toxicity postpartum. And then I wouldn't pull them off or down immediately, but within the first month, you're going to keep in mind, flag them for pulling them down on their antidepressant because of that adjustment up. And then if the patient's having side effects, consider tapering or cross tapering to a new medication. And then, of course, always think about calling PeriPan at a point like this. We are very excited to take your call, I promise. So other things to think about in the perinatal period, if the patient, if you're rescreening them, you're having them come back in after 4 weeks. And if they've seen no or minimal side effects, and they are not, and also no or minimal clinical improvement, you want to consider going up on the medication. If they're having side effects, cross taper or discontinue and then start a new agent. You want to maximize other treatments. And this is really important. The medicines often can't do all the work. The medicines can help lift someone out of a hole, but then they need sleep, emotional support, to be in a group, psychotherapy. They need to be getting out of their house. They need to be getting sunlight in the morning, sort of basic things that are simple and really fundamental to our mental health. And then again, the late pregnancy thing we already discussed. And then remember to continue to see patients regularly, use screening tools to monitor their progress, and then talk to them. They may have a relapse of depression or anxiety that isn't due to medication, it's due to situational stress. And then you get to talk with them a little bit more to figure out what they need. Do they need more support, or do they need a higher dose of medication, or do they need a help with their sleep? What do they need? And then on the right, looking at this algorithm, just continuing to reevaluate patients on medication is really important. Encouraging adherence to the treatment that you're using, and then thinking about when you're going to hand off treatment to another provider. You may be comfortable if the patient is happy on her SSRIs, say, and is doing well, you don't have to hand her off to another provider. You can continue prescribing that if you're comfortable. That is not a problem. But if they're complicated, if they have bipolar disorder, if you are not comfortable continuing the medication, then thinking about the transfer to a mental health provider is, important. Okay, and yeah, what if the patient says, I'm better, now what? What we say is the brain needs time to heal. And when people go off an antidepressant, when they've responded to one, after, say, 3 months, the relapse rates are really high. So a good guideline is having the patient be well on an antidepressant, for example, for at least 6 months in the perinatal period. Ideally, they're postpartum. You've gotten them through the initial postpartum, and you want them on treatment for 6 months. You set a clock, and you want to keep them well, stable on the medicine dose that got them to remission for 6 months at minimum. Some patients, you may want to think about things like, are they still breastfeeding? When are they returning to work? What are anticipated stressors? And time a trial tapering off medicine to when life is somewhat supportive for them. Then if you are ready to taper, some medicines are harder to stop than others. The ones that have a very short half-life predictably have more symptoms of discontinuation, and that is Paxil or paroxetine and venlafaxine. Those are our two medicines that have the hardest withdrawal. The best withdrawal is fluoxetine because it has a week-long half-life. So it's a very easy one to taper off of. In general, tapering off any antidepressant, it's a good idea to go slow and stepwise. I'm kind of conservative. I actually try to get patients to agree with my recommendation to make a change every month and to have it be a gradual one. And reassess, make sure that gives enough time to get through any early discontinuation symptoms and gets you to a point where you're actually assessing whether they are doing okay on that new dose of medication or whether they needed it. Let's see. And then, yes, the question of when to hand off and who to hand off to, a primary care doctor or a mental health provider specialist. Which medication to start with? If you have patients, and we're talking patients for mild, moderate, or severe depression, anxiety, or PTSD, if they've not been on anything else ever, sertraline is an easy one to start with because it has very good safety data for pregnancy, and it also is transferred in very small amounts in breast milk. So it's an easy one, but I just want to say it's an easy one to start with. It's not the only one or the best one. If we're looking at sertraline, starting it at a low dose is the best way to avoid initial activation or other side effects. So some people will feel a little activated or anxious when they start an SSRI. It's turning up neurotransmitter activity. And so that's why we want to start low. Other reasons to start low, people can have initial headache or queasiness, nausea. And so starting low can really minimize those initial side effects. Generally, starting at a half of the lowest treatment dose is the general rule. So that's what we're seeing here across the board. Sertraline, the general therapeutic range is 50 to 200, but we recommend starting at 25. Fluoxetine, dose range is 20 to 80. We start with 10. Citalopram, dose range 20 to 40. We start with 10. And S-citalopram, 10 to 20 is therapeutic range, and we start with 5. Start in the morning and then switch to nighttime if it's sedating. Fluoxetine has some noradrenergic activity. It's stimulating. It can even, people can experience suppressed appetite, and they tend to feel awake on it. So it in particular is a bad one to have people take at night. You can trigger insomnia with it in particular. In general, have people take them in the morning to start, and then if they feel tired, switch to nighttime. They do not need to take these medicines with food. A lot of people are confused. They think it's a good idea to take with food any medicine or any antidepressant, and that's not true. So that can get in the way of adherence if people are trying to wait to take their medicine until they eat and then they forget. So anyway, recommendations are, here we're saying increase after 4 days. That is fine. But what I recommend is you tell a patient, go up at 4 days. If you're still having any initial side effects, don't go up until you feel normal again. And give them some autonomy too. Give them a sense of control over their tapering. It tends to go better. And then this is debated, I would say. Somewhere in our guidelines, sertraline, it's recommended in a lot of the OB-GYN material to go up again to 100 milligrams before you'd expect to see a treatment response, which is usually around 3 weeks. So in our guideline here, we're saying go up again to 100 milligrams at 7 days, if tolerated. That is, honestly, that's up to you. It's not a terrible thing to do, but it's not absolutely necessary. You could do it slower. For any of these, the idea is get them up to a dose they're tolerating that's on the lower therapeutic range, and then give them 3 to 4 weeks, see how they respond, and then adjust upwards if they are still symptomatic. What if the SSRIs are not effective? That first line. Then we have some SNRIs, duloxetine, venlafaxine. I'm not sure why desvenlafaxine isn't on this, but desvenlafaxine should be. So I'm happy to answer questions if you all don't know about desvenlafaxine. I'm going to assume you do, but it should be on this list. And then fluvoxamine, that is specifically for OCD treatment. Paroxetine is very sedating. It has antihistamine qualities. It's also a very active SSRI. So for some people, it is their medicine. It works well. For other people, it's too sedating and it can cause weight gain. Mirtazapine is one that we use a lot during the pregnancy period because it helps people sleep and it is an anti-nausea medicine. It works the same way that that Zofran does, or it works the same way that ondansetron works. Sorry, there. But it is a really great medicine to get to know for pregnant patients. Dose range is 15 to 45, start with 7.5. It's generally very well tolerated except for sedation. And then bupropion is a really great option. It doesn't come with the SSRI side effects. It works by blocking norepinephrine and dopamine reuptake. It is a very mild stimulant in some ways. And it is a great medicine for improving low motivation, low energy, poor concentration. It can make anxiety worse. So psychotropics in lactation, all psychotropics are excreted in breast milk, but some are virtually filtered out. So a little bit gets through, but very little. And that is specifically paroxetine and sertraline. But in general, SSRI exposure is low and significantly lower than through the placenta during pregnancy. So if someone's already been pregnant on an SSRI or SNRI, please do not worry about it. The amount that gets through for exposure to the developing child during lactation is really minimal compared to what the exposure was during pregnancy. In general, we have reassuring data that babies do fine with their exposure to SSRIs. Most of that data is based on case reports, and so there are some case reports of colic, poor feeding, poor weight gain, and you can always bring in the pediatrician. But I would also say, generally in our clinical experience, babies do fine. And if mom's doing well, baby is often doing well too. So remember, keep that in mind, the risk exposure. Other psychotropics, such as lithium and lamictal, have higher infant serum ratios, maternal to infant serum ratios than the SSRI class or the antidepressant class. But they are, well, lithium's complicated and that requires a different talk. It's not contraindicated to breastfeed with it, but it has to be under specific stable situations. Bottom line. And then lamictal, babies do fine with the exposure. We have good data from patients with epilepsy from that population of patients. And in general, we do not worry about lamotrigine exposure in lactation, but it is higher than it can be higher than the 10%, which is what the AAP, or the American Academy of Pediatrics, set as sort of a litmus test. Anything below 10% milk infant serum ratio, or maternal infant serum ratio, is fine. And then the other caveat for all of this is premature and medically ill infants, in which case we are more cautious. And you'll want to bring in the neonatologist essentially to discuss the specific medicine the patient's on. Benefits of so big picture is there are many benefits of breastfeeding. It doesn't always go well, as we all know, and that can impact our mom's mental health. But if it is going well, there are some real benefits to it. And therefore, we're going to do due diligence, and we are going to think hard about allowing the patient to both take care of her mental health and breastfeed. Specifically looking at some of the medicines, this you can all get from LactMed, and I recommend you all get used to looking at LactMed. It is a great resource. It's NIH. It is updated, and it will give you the case reports. It gives you a summary. It gives you information on medication impact to milk supply. So it's a really good source. And as you can see, sertraline is highlighted because it is very low in transmission. Sleep is really important, and that is one of the binds. Sleep for patients in the postpartum period in particular really can support their mental health in a way that no medicine can. And so especially coming off of talking about breastfeeding, there's a balance between allowing a postpartum person to breastfeed and also to get some rest. What we recommend is, as soon as possible, try to encourage the patient to offload one feeding at night where she can sleep through the night, and the baby gets fed and mom gets 4 to 5 hours of continuous sleep. That is immensely helpful to mental health. Here we're looking at other reasons that sleep can be affected in the perinatal period. It's a little beyond what we're talking about today. But there are good resources on trying to support patients getting sleep in the perinatal period, especially postpartum. I'm going to keep going for interest and time. Here we are with some specific strategies in the postpartum period. Try to do the shift. Try to get some concrete help. Help patients understand sleep hygiene basics. CBT insomnia itself treatment, that's going to be for a patient with chronic insomnia. A newly postpartum patient isn't going to have the bandwidth to start CBT insomnia. But CBT insomnia involves a lot of good psychoeducation. So it's a good place to learn about what we know about supporting circadian rhythm. You can use limited time medication to help patients who are highly, highly anxious in the postpartum period and are really struggling to sleep. And we use lorazepam, trazodone, mirtazapine, doxylamine, hydroxyzine are some of our favorites. Doxylamine and hydroxyzine run the risk of lowering milk supply. And so that's one negative for them, but they can be very helpful, and they don't carry the issues with DEA controlled use with a benzo. But use of lorazepam in the early perinatal period while a patient is getting started on an SSRI is really a helpful tool. And then you do need to remind or counsel patients and document that that if a parent is using a sedative, they shouldn't co-sleep due to the risk of rolling over on the baby, essentially. And then also caution with use of sedatives in the context of an ill or premature baby. Communicating with lactation and pediatrics is ideal. Is there a hormonal treatment for postpartum depression? Why, thank you for asking. Yes, there is. There are analogs of the metabolite of progesterone, allopregnanolone, that have been out and used since 2019. The first was brexanolone, which was an IV infusion, very expensive, can't breastfeed on it, big deal, but it was effective for some patients and a great option, very first medicine for treatment of postpartum depression. We got an oral version of brexanolone in December of 2023. It is still very expensive. It is brand name only. However, get to know the drug rep because they can facilitate and help you access it for your patients. Theoretically, patients can breastfeed and take the medicine, although we don't have good data regarding actual outcomes. We only know that the relative infant dose is quite low. But the other thing to know about metabolites of allopregnanolone are they are GABA-A agonists and they are sedating. And so mom may not be able to breastfeed overnight because she's just can't wake up. And also there is significant interaction with medications that are CYP2D6 inhibitors. I learned this the hard way with a patient on fluoxetine 80, where I added zuranolone and she was just so snowed. She hated it. And I learned that I needed to have lowered the dose. And you can do that very quickly. You can put in an order for a lower dose and they will overnight it to you. This is all available through specialty pharmacy. So I'm going to stop now and we'll do the case and then I can do a Q&A afterwards. We can all do that. So should I stop sharing, you all? I think I will.
Yes, thank you, Dr. Horst. We have a couple of comments and 2 questions in the chat already. And I saw that Dr. Ruiz answered one of them. Thank you very much for that, Dr. Ruiz. But I want to allow Susan Treese to unmute her mic and ask her question aloud. And anyone else who has questions, feel free to unmute your mics as well.
So my question was, normally when a person has major depression, one episode, and they come off of it, there's a 50% risk for relapse. And so if you're talking about taking somebody off of their medicine at approximately 6 months or suggesting that or trying that, you need to also be very clear with them that they may relapse, that they could have a very good percentage of relapse rate given that they'd experienced major depression.
You make a very good point. Thank you. So when you're talking to a patient about whether they want to come off their antidepressant at some point, a really important question is this an illness that is sort of their biologic set point? Do they have a history of repeated episodes of depression, for example, or generalized anxiety? If they do, if it's their biologic set point, yes, I will really encourage them to not think they have to go off a treatment that works for them and that they should continue, because in the past when they went off medicine, they relapsed, and that's predictable. Sometimes people can do fine until a stress hits them and then they relapse. And in that case, you can talk to, if they really want to get off the medicine, you can talk to them about anticipating getting back on when life is stressful. yeah, I guess I'll stop there. But yeah, not everyone should come off their antidepressant. Absolutely.
Thank you, Dr. Horst, and thank you, Susan, for that question. I'll allow just another moment for other questions to come in to the chat or from the learning community. Allow them to unmute their microphones. While we wait for additional questions, I do want to prompt Dr. Subrin, who's our case presenter, to prepare for walking us through that case.
Absolutely. I think IT is going to share it, right, for me?
Yes, they will.
Just let me know when. I don't want to follow Dr. Horst. That was incredible. Just let me know whenever.
We have another question in the chat, Dr. Horst, from Lee Mary.
Great. Let me go down to it. Okay. I'm seeing some postpartum clients that are being placed on just a 2-week course of treatment with Zurzuvae. Can you give any info? So Zurzuvae is the brand name for zuranolone, that allopregnanolone analog. It is a specific treatment for postpartum depression. It is only a 2-week course. That's the beauty of it. It is thought to have enduring effects, even though it is only, it is a treatment that is a short course. So that is absolutely correct. It's a 2-week course of the medicine, and in the phase 3 studies, people maintained remission up to 42 days, I believe, is how long they followed. And then they had follow-up studies going up to a year. I will tell you clinically, in our clinic, we are seeing some people respond really well, maybe a third, and another third don't tolerate the zuranolone, and then another third, it just doesn't help. So that's not what the phase 3 studies found, but the phase 3 studies were looking at severe postpartum depression patients, and the indication for zuranolone is for anyone with postpartum depression of any severity.
Thank you, Dr. Horst. We'll now move on to our case presentation for today. Dr. Subrin, thanks so much for presenting. If you would, please walk us through your case.
Sure. Okay. So what isn't provided on your screen is a little bit of the background history. Can I start there, Brenda? Okay. All right. So in late 2024, this patient was diagnosed with myasthenia gravis. I might be saying that wrong. We'd also call it MG. And soon after became pregnant. The patient moved from the Midwest to where I live here in Arizona during pregnancy to reconnect with a previous boyfriend. But that relationship was unstable, and now she is quasi-homeless, pregnant, and has MG. At this time, so fast forward, the patient is now approximately 1 month postpartum. She delivered prematurely at 33 weeks due to a MG crisis. So she has a premature baby. She is 1 month postpartum, and her MG diagnosis is progressing, as well as symptoms of anxiety and depression. Her MG has significantly impacted her muscles, especially in her legs, and mobility is becoming an issue. She previously used alcohol to cope with stress, depression, and anxiety. So that is the history. Here's the notes I didn't include. I think I met this patient at the best and the worst time of her life. This is her first baby, very joyous. The worst time in her life, she's like 1 year into this new diagnosis and very new to single parenthood in a new state. So the consult question here, she is 32, African-American female, heterosexual and sexual orientation. The patient will have long-term medical needs to care for her MG. What referrals come to mind for this group as a priority in caring for her behavioral health and her physical health in the postpartum period? Any considerations or best practices that could guide the management of this patient's bupropion use? She was using a very low dose, 2 milligrams for chronic pain, we think connected to the MG. And that is my patient. I wrote to myself, very complex, Joy. I wrote very complex. That's why I'm here today. I also wrote to myself, anyway, I will not steal the thunder from our crew, but I had a lot of thoughts. And so I welcome ideas. She has depression, anxiety. She has a history of SI thoughts, nothing current. She has no known history of trauma. As you can see, occasional alcohol use during and prior to pregnancy, again, to cope with anxiety and depression. And no known cannabis, no known MDMA, nothing. Nothing. Primary SEDS diagnosis is alcohol misuse, mild, anxiety moderate, depression moderate. In the past, she, in her previous state, she told me she was engaged in counseling, but not now, not enrolled, although offered. And past pharmacological treatment, here's where I wrote that, sorry, 2 milligrams of PRN, buprenorphine. So nothing that I knew of that was inpatient, and she was presently at the MICU for stabilization. And at that time that I wrote this, we weren't sure if she was going to discharge to a SNF or to home. And nothing in terms of a past or present mutual aid support group. It's just been really hard to engage with this patient. I think I had the opportunity to meet her 2 times, really sporadic care. Some risk reduction services. I definitely layered in a lot of ideas about perinatal mood and anxiety support groups. This is a woman who's alone in her single parenthood, alone in her, just moved to Tucson. So anyway, part of the just prescription drug monitoring program, her current medication that is known is the buprenorphine 2 milligrams for chronic pain. And her medical comorbidities are the MG, anxiety, alcohol use, and depression. I think that's the final piece on that page.
Dr. Subrin, do you want to go over your consult questions to kind of direct the conversation, or do you feel, is there anything specific that you're looking for from our learning community?
I guess I would love to know what came to mind for you all first, coming from your lens as an MD, a DO, a social worker, behavioral health. I had a great pre-discussion with 2 of the hub members, and things came up so I just really would love to know what came up for you all.
We have one comment in the chat from Andrea, just wanting to point out that this woman does have a trauma history. She moved across the country for a relationship that didn't work out, and now is having housing insecurity and a newborn preemie, which is super traumatizing. Thank you for that comment.
She is spot on. Thank you, Jasmine. Whoever wrote that to me, sorry. That is spot on. The history is now, right? She has a newborn. Like I said, I mean, this is the best and the worst of times. Very scary. That's not even half of it, of the trauma. She was sedated. She had to have a stat C-section. The ethics committee had to approve it because she was intubated with this MG crisis. So yeah, so thank you for pointing that out. That will really help with care planning in her postpartum period.
Have another comment from Shanaz. Also needs community resources and help in the city, in the new city. I know that you are really great at finding those resources for your patients. Yeah. We welcome other comments and questions. Looks like we have one just that came into the chat from Francis Carrillo. Can you provide more information on what MG is and how it will impact her short and long term?
So I'm going to call upon the definition because, again, I'm not a DO or an MD. So MG is, I would be stumbling over my words. So I'd rather read this definition that I like. It's a chronic autoimmune disease causing fluctuating weakness in your voluntary muscles, such as your eyes, your face, your throat, and your limbs. And this was the throat was the issue. It became such shortness of breath that she had to be intubated, and that was an MG crisis. Key symptoms include drooping of eyelids, double vision, difficulty chewing, swallowing, speaking, and breathing with severe flare-ups, potentially impairing breathing. While there's no cure, treatment can help manage symptoms, allowing many people to live fulfilling lives. So it is an autoimmune disorder that affects the chemical in our brain that helps us do movement, muscle movement, in short. So it was pretty devastating, very traumatic, like our other guests said.
We had a question in the chat from El Luciano. I want to give El a chance to unmute and ask that question aloud.
Yes. I can read it for her, unless she can unmute. Sure. Hi, Elle. I'm not sure where you are in there. Is there also a concern about her ability, being able to keep custody without housing? I would imagine that's the utmost priority. Absolutely. Oh, she said she doesn't have a mic. That's okay. So again, this was just so very complicated. Yes. So you can't live in a car, right? Housing was unstable with the ex-partner. So I started to think, would she be willing to go maybe to residential, anything? And or is there a housing program through SSDI? How fast can I get her on SSDI? Ultimately, her mom came from out of state and was able to get like an extended stay, which was really helpful. It's all very temporary. You know, this is a baby that's still in the NICU. So you're absolutely right, Elle. There is a risk of who can take, I wrote some notes to myself, temporary guardianship versus guardianship. You know, we want to have a good outcome for both mom and baby, but there is a concern, yes.
We have a similar concern and question from Andrea Albrecht. Andrea, if you have a mic, would you like to unmute and ask your question aloud?
Sure. So is there a reason she can't go back to the Midwest? Like, is the father there keeping her there with custody issues, or does she have a support system to go back to?
Andrea, you read many of our minds, you know. Is there a chance? I wrote to myself, what are her goals? What does her quality of life look like? Now that the baby's here, the relationship with the ex-partner did not flourish. So that I wonder, when this baby is discharged, if the stability of home in the Midwest is an option. And that's how I would phrase it. You know, is it an option? So she has that autonomy. But yeah, there was no fleeing from domestic violence. There was just all of a sudden a launch to to Arizona to be with the ex-partner. Yeah, I think evaluating, you know, where you have most of your family this is a critical time to do that. Thanks for your question.
And we continue to welcome comments and recommendations or questions from our learning community. Feel free to unmute your mic or drop those comments and questions into the chat. If any of our Hub team members have any recommendations or questions, please feel free to unmute and offer those now as well.
Hey, so Dr. Subrin, the first few things I thought of when I was looking through it from a medical perspective, MG typically causes a muscle weakness, but not pain. You can have some mild pain, but that's not like an overarching symptom of that. And so it's interesting to me that she's labeled as having chronic pain and is taking buprenorphine for that. Also, the buprenorphine dose being used is so small. It's not what we typically use in someone with chronic pain. So I would be interested, you know, if I was seeing this patient, hey, tell me more about your pain. Do we actually have a chronic pain? If we don't, I wouldn't necessarily want her tied to buprenorphine. That would be another thing that she has to keep up with. And if it's not necessary, let's not do that. I don't know. So I'd really want to dig into that a little bit. Secondly, I know she's not on anything for anxiety or depression or anything like that. So I'm interested about that. And third, for MG, for like long-term function, we typically recommend like more physical therapy and strength building and things like that. I think that would be very difficult for her to do given her housing situation and having a premature baby. But something to look forward in the long run to help improve her functioning. So those were all my initial thoughts when I looked over it.
And I'm so grateful for you bringing that up now and previously, because I just think there is something misaligned. You know, I think if she could be on one of I took a million screenshots of Dr. Horst, not that I'm a prescriber, but what medication could help her with functioning? Like, why isn't she showing up for appointments? Why aren't we focusing a little bit more on the anti-anxiety or depression or low functioning medication? And can we clarify where this buprenorphine came and where the pain is? So
The
yeah.
2 milligrams of buprenorphine as needed just seemed out of the blue to me a little bit. Like I was
Yeah.
just like, I see patients with chronic pain on buprenorphine of 24 to 32 milligrams, and
Right.
she's on 2 as needed. So that didn't
Yeah.
quite line up.
Yeah.
It was just a little bit of an oddball stuck in there. And she didn't
No.
have a history of opioid use disorder either. So
No.
it was just weird.
Yeah, I hope, although I think maybe her familial support is better out of state, I do hope to see her again before she launches. This baby's still in the NICU, so she's not moving for a while. To ask her, in just a year and a half since this diagnosis, can we talk about where these medications started? Where do you see them go? We need some guidance. So I'm excited for her to have improved health, and to be part of it from my little lens in the social work world.
Thank you, Dr. Subrin. I
Yeah.
appreciate the conversation, and thank you for the continued comments and questions in the chat. Dr. Subrin, I would encourage you to look at those
Yeah.
questions and comments. We'll continue to take them in the chat. Again, you can access the chat feature by clicking on the speech bubble icon in the Zoom toolbar. We'll continue with our final announcements just in the interest of time. In order to receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's provided in the chat or on the instructions on how to receive credit document that's been posted to the content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. For specific questions about CME credit, please email or call the TTU CME office directly. You can scan the QR code, which is on the screen, or click on the link that's in the chat to complete the session evaluation, which will be available until 11:59 p.m. today. If you already have your account set up with the TTU HSE CME office, you can use the text-in feature with the code 39939. The text is only available until 11:59 p.m. today. Do you have a difficult case that you or your team have encountered? Let's tackle it together by bringing your challenging or complex case to the Maternal Health Echo. You'll get support from a team of experts and fellow providers. There's no need to prepare a formal presentation. We'll provide you with a case form to fill out to assist with your case presentation. You can email us at the email address that is listed in the chat right now, cstat@uthscsa.edu, to present a case. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthscsa.edu/contact-us, and we'll be pleased to help you. Registration is now open for the 2026 Texas Substance Use Symposium, or Texas. Join us March 2nd through 3rd at the Henry B. Gonzalez Convention Center in San Antonio, Texas, for 2 days of learning, collaboration, and connection. To learn more, please visit the website that has been dropped into the chat. And you can partner with Texas to showcase your organization, support statewide collaboration, and connect with substance use professionals across Texas. For more details on sponsorship and exhibitors opportunities, please contact us again at that email address that is in the chat, or visit texas.org/sponsor-TX-Texas. The Texas Substance Use Symposium invites you to submit a poster proposal for Texas 2026, which is taking place on March 2nd through 3rd at the Henry B. Gonzalez Convention Center in San Antonio. The poster submission deadline has been extended, and we are now accepting proposals through January 25th of this year. We welcome submissions from professionals across the substance use and behavioral health fields to submit proposals now through January 25th, 2026. Share your expertise, innovative practices, and research with a statewide audience dedicated to advancing recovery-oriented systems of care. Learn more and submit yours today. I will pass this presentation on to Jen Ertegy with Perinatal with the PeriPan program, who has a few announcements, and we'll wrap up with a final announcement from Dr. Mohammed Chaudhry. Jen?
Hi, just going to provide a real quick overview of PeriPan. We were created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, which affects 1 in 5 perinatal women. You can see that PeriPan has 4 components on the slide, and we provide clinical guidance to help with single patient case or enhanced mental health care in your practice as a whole. Next slide. And we are anchored by 12 medical schools across Texas, as you can see on this map. Signing up is really easy. Each region does have their own unique texting number, which you get provided at sign up. So you just call the number on the screen to enroll. Next slide. And we would love for you to join our PeriPan webinar series, which is held on the 3rd Tuesday of each month. We are excited to share that this month we launch a fresh lineup of sessions, which starts with the continuation of psychopharmacology, common psychotropics for maternal mental health conditions. So these webinars complement the echoes by offering a deeper clinical insight and opportunity to learn directly from experts in the field, like Dr. Horst. So on the screen, you just see a list of upcoming topics, and we'll put in the chat how to register. And then on the final slide, it's just our upcoming Echo series, which are held on the first Tuesday of the month, like today. And we will be sharing the rest of the 2026 topics shortly, because right now we're just through March topics, but we will be sharing that information shortly. Thank you.
Thank you. And I'd like to ask Dr. Chaudhry to share his new announcement.
Hello, everyone. I'm Dr. Chaudhry. I am an addiction medicine provider here at University of Texas at San Antonio. And I wanted to give a brief update on the prescription of Suboxone and how it is impacted by regulations from DEA and the HHS. So just a little bit of context. Before COVID time periods, you needed an in-person evaluation to begin anyone on a controlled substance, including Suboxone or buprenorphine. But during the COVID time period, the DEA and the HHS allowed for certain flexibilities. One of the flexibilities was that these medications, including Suboxone, could be prescribed on a telemedicine basis without an in-person evaluation first. And this greatly expanded the access to MAT or opioid use disorder care for a lot of patients, specifically in rural areas. And the DEA has been extending these flexibilities for the last couple of years, and they were set to expire at the end of 2025. And so in the beginning of 2025, the DEA made a new rule that in order to allow for this expansion to continue in terms of the Suboxone prescription, their new rule was that you can start someone on Suboxone without an in-person evaluation by only a telemedicine visit for the first 6 months, but they have to have an in-person visit within the first 6 months of their starting of Suboxone. This rule was supposed to take effect from the beginning of 2026, but at the end of 2025, the DEA and HHC on the last day of 2025 made this announcement that they are extending the COVID flexibilities for another year. So for 1 more year, Suboxone can be prescribed via telemedicine without the need for an in-person visit. And this flexibility will now expire at the end of 2026. And that is it.
Thank you, Dr. Chaudhry, for that update. A very important update for everyone who's on this call today. And before we wrap up, I welcome Dr. Emily Humphrey to provide our session summary and case recommendations. Dr. Humphrey.
I'll be super quick. So after the presentation, big takeaways were a half of pregnancies are unplanned. So we will likely see many women coming in that are already on medications for anxiety and depression. Lowering the dose or tapering off the dose is not recommended. Close follow-up after they have baby is recommended, and we might need to do some dose adjustments during the 3rd trimester and postpartum and so on. We want them on a good stable dose for at least 6 months. And before tapering, consider prior relapse, whether they're stopping breastfeeding, going back to work, etc. And also sleep is very important. So help that mama get sleep at least 4 to 5 hours. And for case recommendations, it sounds like trying to really capitalize on good social supports, figuring out where she can get the most bang for her buck, whether that's moving back home or staying where she's at, and digging into her medical issues a little bit more and capitalizing on those medications out there that could be most helpful.
Thank you, Dr. Humphrey, and thank all of you for joining today's Maternal Health Echo. We extend our appreciation to Dr. Karen Horst for her presentation and Dr. Subrin for her case presentation. As a reminder, to earn CME credits, please complete the evaluation using the link that's been dropped into the chat. And if you have a case or scenario you'd like to share, please email the CSTAT team. We look forward to seeing all of you at our next session on Tuesday, February 3rd at 12 p.m. Central Standard Time. Have a great rest of your day and Happy New Year, everyone. Bye-bye.